So I think I'm going to talk one of the most important and the easiest part on how to manage women of childbearing potential. It's just to act at every time point with the women and involve all the medical and all healthcare providers in the prevention of malformations and teratogenicity. These are my disclosures. And then my presentation is based on the recommendations published in 2005 by the Central Disease Control in the US on the different pathologies that can be assessed before those women to get pregnant, like diabetes, HIV infections, obesity, and of course, epilepsy. The objectives of preconception health and healthcare is as a part of the primary care visits, provide risk assessment and educational and health promotion counseling to all women of childbearing age to reduce reproductive risks and improve pregnancy outcomes, and increase the proportion of women who receive interventions as follow-up to preconception risk screening, focusing on the high priority interventions. So the rationale for targeting preconception health activities to women with epilepsy, this specific pathology, is that nowadays, all over the world, approximately 50% of the pregnancies are conceived without an intent. And even in those women where the pregnancy was intended, many of them have not discussed the desire or plans to conceive with the medical provider. Women with epilepsy often has a routine follow-up with neurologists or other health providers. But however, medical providers often overlook the ramifications of the pregnancy as they address all the women's chronic disease needs. And sometimes the opportunities to provide that important information is missed because the healthcare provider goes on to other specific situations, and all the information that the patient needs is missed. What is the role of the clinician in that preconception care? So we have to think that in a woman of childbearing protections from the very beginning up to the menopause is an opportunity to address preconception needs, to prevent unwanted pregnancies, provide preconception counseling if pregnancy is desired, and encourage the women and the couples to actively choose when and how probably to become pregnant, provide general health promotion and disease prevention guidance. One thing that is important is not only the pregnancy, it's the family planning. It's basic to have a reproductive life plan to encourage the patients and the families to have a life plan to have families, appropriate contraceptives. It depends on the different cultures. We have many countries here. But overall, we have to recommend women how to prevent undesired pregnancies. So the effectiveness of the hormonal contraception, which is probably the most common type of contraception used all over the world, is risky from some of these women because we have to assume that the failures of the oral contraceptives in patients taking antiepileptic drugs is higher than in the general population or patients not taking these drugs. The preconception care for the women with epilepsy, we have to outline the importance of actively planning for any conception. Start folic acid, and even at the higher doses that in patients not taking antiepileptic drugs. They have higher risk of malformation of the CNS in the newborn. So if we increase a little bit the doses, we can avoid those malformations, taking that folic acid before the pregnancy and during the first trimester. And of course, evaluate the maternal condition and assess the plan for treatment, engaging GPs, obstetrician, and of course the neurologists. We have to remember to wean or change different antiepileptic drugs, and the objectives of the target of the treatment is like to reduce the doses of the different antiepileptic drugs as much as possible and keep the patients with no therapy if possible, or with a monotherapy at the lowest doses. But remember that seizures are a risk factor for teratogenicity as well. So counsel the need to adhere to the treatment to your patients. So it's not the first time that a patient comes to my clinic, she's pregnant, and she said she stopped the treatment by herself because she thought that it was teratogenic. We need to avoid that situation. But then we go for the main problem that we have nowadays. In some symptoms, some epileptic syndromes, we know that valproic acid is a very important treatment. There's the main treatment for this woman of childbearing potential. So there are some risk minimization measures for valproate, but all the, probably neurologists, of course, but the healthcare providers need to be informed. So as Bettina introduced us before, in October 24, there were some restrictions on the use of valproate or substances containing valproate that basically were the educational materials for physicians and patients implemented trying to avoid this healthcare provider to use valproic acid. However, 4 years later, there was no, or 3 years later, there was not an expected response from the medical community, and the prescriptions on epilepsy and bipolar disorders were likely the same. And then the EMA recommended a more strict restrictions in the use of valproate with the introduction, with the implementation of a pregnancy prevention program. Basically, the new pregnancy prevention program is in the treatment of epilepsy, tries not to use the valproic acid in women of childbearing potential unless the conditions of the pregnancy prevention program are fulfilled, and use valproic acid in pregnancy women unless there is not other suitable alternative. So one of the most restrictions are the problems in the follow-up of these patients using valproic acid during the childbearing age, the potential age, is that we need to test the pregnancy, we need to make pregnancy tests before starting the valproic acid treatment, and then in the follow-up, we need to do regular pregnancy tests to assess the patient to ensure that there is no risk for the future newborns. So the purpose of the revised measures is to avoid any unnecessary exposure to valproate during the pregnancy and to further increase the effectiveness of the communication to healthcare professionals and the understanding of the patients and the awareness of the educational materials. There's a revision of the labeling. We have an outer box warning, a pictogram, QR code, where the patient or even the doctors can have access to the full information on the pregnancy prevention program. That implementation of the pregnancy prevention programs, which include measures to ensure that healthcare professionals are aware of the risk and recommendations on the use of valproic during the pregnancy, ensure the patient's information, and finally counseling on the need for effective contraception, pregnancy planning, and an annual visit with a specialist. The best way to give that educational materials is creating a web-based platform where all healthcare professionals and patients can have access, and then there is a full description at every time point if the patient is pregnant, if the patient wants to get pregnant, how to proceed with the risk minimization measures. So the pregnancy prevention program in patients treated with valproate is a full educational program that includes guides for healthcare professionals. There's a patient's guide, the patient's card, and there is an annual risk acknowledgement form that the patient needs to fulfill and sign. So in the educational materials, a direct healthcare professional communication has been distributed to raise awareness of the new recommendations with the key elements of the product information and the pregnancy prevention program. But we don't have to forget that pregnancy and epilepsy is not all about antiepileptic drugs. The women of reproductive age with seizure disorder should be counseled about the risk of increased seizure frequency in pregnancy. We have to consider each individual case and give information to that patient. The potential effects of the seizures in the fetus or in the newborn, and then the antiepileptic drugs and pregnancy outcomes, and the need to plan their pregnancies with a healthcare provider in advance of a planned conception. And it must be done from the very beginning of the follow-up of that patient for the very first diagnostic of epilepsy. Don't wait too long. So in summary, the preconception healthcare promotion is part of the routine primary care in women with epilepsy. As I told you, from the first visit, we have to consider to give the information to the patients and the relative. The preconception care is not an isolated activity. We must involve all the medical community, GPs, obstetricians, nurses, neurologists, internal medicine. Everyone should be informed and involved in the preconception care. The pregnancy is part of a life course perspective on women's health. And finally, the pregnancy desire should be evaluated at each visit. We all know that a woman that doesn't want to get pregnant in one visit, maybe 6 months later, is the primary desire of her life. So we must consider and assess at each time point what is the pregnancy desire of that patient. The AEDs and lifestyle should be optimized during the preconception period. And finally, all of us should be aware of the risk minimization measures for valproic acid or have access, or where to know to have access to that information.